All right, team, welcome back. I know exams are right around the corner, so we're going to crank through a super high-yield topic for your boards, autoimmune hepatitis. Let's get right into it. So first up, what exactly is this thing? Well, autoimmune hepatitis, or AIH, is a chronic liver disease where the body pretty much gets its wires crossed. Your own immune system, the thing that's supposed to be your bodyguard, mistakes your liver cells, your hepatocytes, for the enemy and just starts attacking them. It's a classic and pretty nasty case of friendly fire. So, what's really going on under the hood here? Let's dig into the basics, the pathophysiology, and the risk factors that set the stage for this whole thing. Okay, so AIH doesn't just come out of nowhere. You can think of it as the result of a perfect storm. It all starts with a genetic predisposition. And for your exams, you absolutely have to remember the HLA-DR3 and HLA-DR4 genes. Then, some kind of environmental trigger, which we honestly don't fully understand yet, comes along and flips a switch, kicking that predisposed immune system into overdrive against the liver. Okay, so we've got the why. Now let's talk about the who and the how. How is this actually going to look when a patient walks into your clinic?
And here's a huge clinical point. The presentation of AIH is all over the map. It's a huge spectrum. On one end, you might have a patient who is completely asymptomatic, and you only catch it because of some weird lab results. In the middle, you get those more classic symptoms, a little fever, jaundice, maybe an enlarged liver and spleen. But on the far end of that spectrum, you can see someone in full-blown acute liver failure, or with chronic problems like bleeding issues.
Now this slide, this is pure gold for your exams. You have got to know the different types, which we classify based on their specific autoantibodies. Type 1 is the big one, the most common, and you'll see ANA and ASMA antibodies. But type 2, that's your classic board question. It's marked by ALKM1 antibodies, and you see it a lot in young women. Knowing these types is a great clinical pearl because it helps you piece together the puzzle of who your patient is and how their disease might progress. So you're starting to suspect AIH based on the patient's story and their symptoms. How do you go from suspicion to a confirmed diagnosis? Let's walk through the workup. The lab work is going to give you some major clues. You'll see those liver enzymes, ALT and AST, are sky high, which just screams liver cell damage. But you'll also see signs that the liver isn't doing its job, its factory functions. Albumin will be low and the prothrombin time will be increased. That just means it's taking longer for the blood to clot because that damaged liver isn't making enough clotting factors. But the absolute gold standard, the thing that seals the deal, is a liver biopsy. And when you look at the histology, you can literally see the attack happening. All those dense little purple dots, that's the immune system's army, lymphocytes and plasma cells that have swarmed into the liver tissue, causing all that inflammation and chaos. This image is the smoking gun. Okay, the diagnosis is in. It's time to take action. Let's cover how we manage AIH and what we're trying to prevent down the line. The whole game plan here is to tell that overactive immune system to just calm down. The first line of attack is immunosuppressants. We usually hit it hard and fast with corticosteroids, like prednisone, to put out the fire. Then we use other agents like azathioprine for the long haul to keep things quiet. But if the drugs don't work, or the disease is too advanced, a liver transplant is really the only definitive life-saving move. So what are we trying to stop from happening? Well, if you don't treat AIH, it can lead to some really serious stuff. Cirrhosis, liver failure, even liver cancer. But, and this is the tough part, the treatment itself has risks. Being on immunosuppressants for years can actually increase the risk of other types of cancers. So it's this constant, tricky balancing act. And that really brings us to the central challenge, the million-dollar question in managing autoimmune hepatitis. How do you, as a clinician, balance that urgent need to protect the liver by suppressing the immune system without opening the door to future problems from that very same suppression? It's a critical question, and it's one that doctors and patients navigate together every single day. Thanks for tuning in.